Are you one of the millions with a health condition that requires you to use needles? If so, please listen. Disposing of your needles properly is a big responsibility. Accidental needle sticks in the home can injure family members, children, and even your pets. I am Dr. Drew Pinsky, and I have an easy solution for the safe disposal of needles and the end to accidental needle stick injuries. You may have heard about Sand Mini. The Sand Mini is the affordable, foolproof way to dispose of needles. It's FDA approved, and with Sand Mini, it is easy. Just insert the needle, press the button, and in seconds, the needle is incinerated. Now you have a needle that is completely safe to discard. No sharp points, no bacteria, germs, or pathogens. Make sure your home and business is sand safe. Every needle, every time. Go online right now and use our special promo code DREW2020 for our best offer ever on the Sand Mini. That's nomoresharps.com, and remember, use my promo code DREW2020 for our special offer. The chat isn't on.
Hey everyone, it's a dose of Dr. Drew.
Now the chat is working. Thank you so much, guys. Hi, Tom Cigar. Welcome, everybody. What's the title change? They're saying change the title, Susan. That's going to scare people away. I'm not quite sure what you put. And no sound. No sound and change the title.
Oh, come on. You guys, turn up your computers.
Tell us if we got sound yet. Good morning, Julia, which I still don't know what that means, from Tom Cigar.
Sound is good.
Okay, great.
I love it when people have technical problems and then they tell me it's my fault.
And they said there's something wrong with our title, too. So anyway, listen. Eric Peterson, you're asking that California has the most cases now. I would hope so. We have the most people. If we did not have the most cases in the country, it would be weird, right? Last I checked, we had 10% of the cases and 12% of the population. So we still aren't at our par in terms of the actual population density. So here we go. I
don't know why forget the headline, okay? It didn't go through. It's fine. We have an amazing guest today. Shall we introduce her, and then
yes.
we can give our information. She's Dr. Kelly Victory.
Yes, it's not Jay Moore, as the title says, Tom Cigar. Thank you. Kelly Victory is not Jay Moore.
I'll go back and change it later.
Dr. Victory is obviously a physician, and she is a frequent guest on various radio programs, as well as other places out in social media. And Susan keeps hearing her and kept coming home going, "You've got to talk to Kelly Victory. You've got to talk to her. You guys would really love talking to each other. She's so great." And lo and behold, here we are. Kelly, welcome.
Thanks for the invitation. I appreciate it.
So I almost don't know where to begin. I guess the easy place to start is what in the world has happened to our profession. It is what got me into trouble yelling about back in February. I could see the sea change a-brewing. I could see the hysteria coming. I could see this giant wave coming our way. And I tried to push back on it and help people navigate their emotions by pointing out that we had an H1N1 in 2009, which infected 500 million people, killed 600,000. We've only got 16 million coronavirus cases in the world, not 500 million like H1N1. So not that I'm saying coronavirus isn't serious and shouldn't be taken very seriously and it isn't something for us to pay attention to. I'm saying the panic is disproportionate. Do I have any point there, Kelly?
You're spot on, Drew, and that's been my point all along. I have never claimed that COVID-19 isn't real, that the virus isn't real, that it doesn't have the potential to profoundly impact certain people. The great news is we know who that group of people is, and so we can address it. The panic and the response has been unprecedented. Although I'm a trauma and emergency physician by training, I made the transition 2 decades ago into disaster preparedness and response and public health. And in my career in public health, I have never seen this sort of thing happen. This has become highly politicized. It's been the most divisive thing I've ever seen in my career in medicine. And you are exactly right. There's an emotionality about the response and an emotionality about the conversation that supersedes anything that we might even vaguely refer to as science.
Right. So now we have, to me, one of the bottoms we hit was where the New York Times board of editorials demanded a lockdown, as though they were public health officials or they should be dictating medical policy. And the thing I've been saying from the beginning is anyone talking to physicians about this? Doctors that are used to making risk-reward analysis, risk-reward decision-making, that if we do non-pharmacological interventions like a quarantine of the public, which, by the way, has never been done before, we will talk about that. But if we do something like that, it will have terrible consequences somewhere else. And now we're in the middle of that.
Right. And what I try to explain to people all the time is that let's look at the mandate of public health, Drew, is always to look at the broad reaching ramifications of any particular response measure. It's very different than when you or I might be sitting in an exam room one-on-one with a patient.
Right.
Our mandate at that point is very, very different.
Yes.
So when I hear people say, whether it's public health officials, and I cringe, or people in the mainstream media say things like, yes, but if we can just save one life. And I think, no, that is not the mandate of public health. We are making public health policy that is impacting huge numbers of people. Tens of millions of people are being impacted by some of these mitigation schemes, such as social distancing and mask wearing and locking down schools and all of these other things that we can talk about. But be very clear, public health has to look at the impact of any of these strategies on the entire population, not just on one individual, which is not to say that you or I or any other caring physician doesn't feel badly, that we don't mourn the loss of people who become ill and die.
It goes without saying. To me, the two fallacies are, well, how many deaths then? How many are we supposed to tolerate?
Right.
I don't know. How many we tolerate from heart disease, lung cancer, pancreatic cancer? You don't think that way with diseases. Diseases determine how many deaths. We struggle with trying to diminish the number of deaths. How many is acceptable? Of course, we'd love there to be none, of course. But we can't determine a priori what the number of deaths are that we're going to be struggling with. It's the disease that determines that.
Well, even with, if you look at, say I said, I don't ever want there to be another death from motor vehicle crashes. This is insane. We have too many. So the quickest way to do that is eliminate motor vehicles.
Well,
okay.
How about with the going back to schools, which is a 12-year-old died in Wisconsin. Too much. One death. Well, from now on, then 12-year-olds cannot swim. You have to get rid of swimming pools altogether.
Right.
Bicycles, forget bicycles. In fact, no sports. All that must stop if one 12-year-old death is too many. I guess we're going to have to keep the 12-year-olds at home forever. And even in the home, there's a little too much risk. I don't know. We're going to have to make... It's just such insanity we're doing now. Such insanity. And by the way,
right.
Before I let you answer, Dr. Victory, those of you on the thread, on the chat, you're chastising me. I see that. I'm too engaged with Dr. Victor right now to watch you guys. I apologize. I will get back to the chat. I promise I will get you guys. Susan, if you could note down any questions that come along that should be addressed, I will happily get back to them. But we're too busy right now with Dr. Victor.
Yeah, we'll get to your questions.
So go ahead.
We're watching.
One is too many.
No, so I think that fundamentally is where part of the problem is, that they've conflated a death with a failure. And unfortunately, when we are in the middle of an epidemic or any other disease process or any other, problem that happens as a result of trauma, as you said, drownings or car accidents or any, bicycle accidents, we have to balance as people in public health. How much can we do to mitigate risks? What is reasonable within the societal norms, within, taking into account people's civil liberties, that people have a right to make choices to do things that might be dangerous, whether it's riding a bicycle or driving in a car or swimming in a swimming pool. So instead we say, okay, well, we'll enact seatbelt laws and speed limits, and we'll put airbags in cars, so we enact certain public health measures. But then at some point, there is an element of risk, and we are not here to remove all of that. So here we find ourselves in a pandemic, And people have sort of lost sight of that, and they keep focusing on individual deaths, individual illness. And unfortunately, we can't do that. We need to mitigate risk as best we can within the realm of what's tolerable.
And understand that if we take excessive interventions, we will cause suicides, substance deaths, poverty. I mean, all these other things, a delay in the treatment of things like heart disease and cancer that will accelerate the death rate in other areas. That's a diathesis that you and I are used to looking at. Governors are not. They just are not. And they've been, they keep saying they're following the science. They aren't. They really are not.
No, in fact, what you're just referencing is what I call COVID lateral damage. It's all of the deaths and suffering and loss that people are suffering as a result of our response rather than the virus itself. And it's a very real entity. We've seen huge uptick in substance abuse, as you well know. Malnutrition, child abuse, depression, suicides, and delay in care. And a lot of the uptick recently in hospitalizations and ICU admissions hasn't actually been COVID-related admissions. There are people who got sick weeks ago and delayed care, didn't come in for treatment for diabetes, heart disease, cancer, whatever it was, and they're showing up in the ER, and we're saying, why didn't you come in 2 weeks ago when you started having chest pain? And they said, because I was scared.
100%.
I didn't want to get exposed.
100%.
COVID lateral damage, and it's a real thing. The CEOs of both the Mayo Clinic and Cleveland Clinic wrote an op-ed back on June 9th saying that in their estimation, deaths from things other than COVID as a result of the lockdown were going to far exceed deaths from COVID itself.
We are seeing that already. That is absolutely true. In the meantime, the press, let's hang out there. Hospitals are overwhelmed. Implication, overwhelmed with COVID. Then you look at the data, 13% of the beds have COVID. The rest is the consequences of delayed treatment. The rest of it.
Another piece of that, Drew, that the mainstream media doesn't report, they don't give context to the numbers. I see these sensational headlines on a daily basis.
Yep.
ICUs at 88% capacity.
Yep.
Here's what they don't tell people. Hospitals aim to keep their ICUs somewhere between 90 and 92% capacity.
Right. So
that's where they want to be. Hospital censuses, they aim to be at 85 to 80% capacity. So if your ICU is at 88%, the CEO is sitting in his office saying, if we don't get some more patients in there, we're going to have to send nurses home and techs home early.
And they may actually have the beds, they just don't have the staff. This is a game that they play all the time, which is they restrict the staffs to the last moment and then open the beds and add the staff when they can no longer wait. But that goes down as a full ICU, even though there's maybe an entire unit open. Exactly right. And that's something that the lay person doesn't have any reason to know, but it's irresponsible for the media to report these as sensational numbers without giving context to them, which is that we are not maybe there have been a couple of hospitals for the duration of this outbreak that have gotten to capacity or needed to go on bypass. But as you rightly point out, we do this all day, every day in hospitals. All the time.
There's a person whose job it is to manage census.
That's right.
We do this in real time all the time.
That's right. If I really believe if somebody else had been president, this story would have been second or third story on the nightly news, would have been doctors are struggling, they're setting up tents, hospitals are full, wear your mask, be careful, we're going to get this thing. Anyway, on to China, on to whatever news. You know what I mean? It would not, but instead, we've gone into total crazy mode, which here we are. And the other bottom, in addition for me, the editorial board demanding a lockdown, which is those, really they should be sanctioned in some way. I canceled my New York Times subscription. That's my sanction, because I love the New York Times. I love them. And now I cannot stand to even look at the headline, the heading of the page, because of particularly of that moment, but many others since. But the other bottom for me is a medication that I've used for 30 years, that you've never heard the name of before, that you suddenly have an opinion on how doctors should use a medication now, Plaquenil is a medicine I've been using for ankylosing spondylitis, rheumatoid arthritis, lupus, all kinds of things, 4 decades. I've had people on it for decades. We'd tell them, hey man, you could get corneal deposits, and there's a rare retinal thing after 10 years, so see an ophthalmologist every year. I never saw any ophthalmological consequences. In fact, I never saw a single side effect from years of use. I cannot say that of acetaminophen Tylenol. I cannot say that of aspirin, but I can say that of Plaquenil. And how in the world does Joy Behar, who now is telling a senator that he was going to kill himself because he took Plaquenil, or hydroxychloroquine as you all know it, that was the other bottom for me. That lay people now having an opinion on how we should practice medicine. And now we're at the point where it's being restricted at the pharmacy because of the hysteria around the drug. You all saw the video of these physicians who by the way, are not just physicians. They were the researchers that blew the lid off of some of the faulty research that was presented in the Lancet. That was an abomination that stopped all the hydrochloroquine research that will, I promise you, show that there's some utility to the drug early, because we all know that. We've all used it. We've all seen its utility. But it's got to be proven for legitimately. It's not a drug for late in the disease. We know that. That's been proven too. We got that. No one else should have any opinions about it except the medical community. What do we do about that?
I agree with you. This has been absolutely insane, and I've never seen it before with any other drug in my entire career in medicine. Let's be very clear. Hydroxychloroquine has been FDA approved for an excess of 6 decades. We started using it somewhere in 1948 for the treatment of malaria, and then subsequently for things like you were just mentioning, rheumatoid arthritis and lupus in particular. Has a very, very good safety profile. It's been FDA approved. It's been on the list of essential medications worldwide for 50 years.
And as some of those doctors pointed out, I think they were in front of the Supreme Court or something, that it's available as chloroquine, which does have some side effects. It's available as chloroquine, not hydroxychloroquine, over the counter worldwide, because it's used so routinely for malaria prophylaxis.
Exactly. But the thing that Americans don't seem to understand, and it's because it's been muddied over this issue, is that the FDA does not control how a physician writes a medication.
Not at all.
Once the medication is approved, meaning it's proven to be safe, then I, Dr. Kelly Victory, or you, Dr. Drew Pinsky, can write that medication for anything you want. There are lots of things. We take a medication, Neurontin is a seizure medication, but we use it commonly for chronic pain. Verapamil is a blood pressure medication, but lots of people have tried it for migraine headaches.
Yep.
I could give example after example. The FDA doesn't control that. The only thing the FDA controls is whether or not it is safe, and therefore your body doesn't know whether you're getting it for COVID-19 or for lupus.
Right.
It doesn't become unsafe.
They determine whether a company can bring it to market, essentially, because it's safe and proven. How we use it, they have nothing to say. They cannot tell us anything. They give us a legal frame within which we are more safe in using it, but that's it. And listen, a lot of medicines we use on a daily basis have never had FDA approval. I think isn't thyroxine, I think, if I remember right. Synthroid never had the FDA approval.
Right. And so the only
aspirin's never had FDA approval.
The only people who should be involved in the discussion of whether or not I write a prescription for hydroxychloroquine for COVID is me and the patient.
Right.
That's it. I didn't invite the FDA in, the mainstream media, Joy Behar, the pharmacy board, the medical board, or anybody else. I don't care what anyone else's opinion is. That's a decision between a patient and a physician.
Yep, that's right. And so what did you think of that video of the docs in front of the government buildings?
Well, I thought I was supposed to be there in person. That was
okay, fair enough.
Summit. I was supposed to be there, but my own clinical obligations and media obligations precluded me from going. It's a group of people that I meet with regularly on a weekly basis via video. And that's why I'm aware of hundreds of physicians around the country who have been using, amongst other things, hydroxychloroquine for the treatment of COVID since probably mid-March. And so I'm aware of the huge body of data that we have collected. So I was happy to see them go. The physician who got the most attention was Dr. Stella Manuel, who is a family practitioner down in Houston, an extraordinarily passionate woman who has treated upwards of 350 people with hydroxychloroquine, and she's had remarkable results. She's treated some very high-risk people. She's in a high-risk, her population or her patient demographic is high risk, a lot of patients with obesity and diabetes, and she reports no deaths in those people who she's treated early.
I think she said, did she say no hospitalizations too?
She had a couple hospitalizations, but no deaths is my understanding. But what was fascinating to me, Drew, is how much offense people took at that video. It's been taken off of all social media.
It's electronic book burning. We are in the burning of the bonfire of the vanities. The books are being burned. They're just being burned electronically. And this is now an example of that.
Exactly. So she and I spoke, and she was very upset about it. And I understand that. A video that I made a month or so ago was taken down. And the reason that YouTube gave me that mine was taken down, it was an informational video about COVID-19 that was made actually for a church, but it was taken down. And the email that I received from YouTube said that I violated the community standards of YouTube because I made statements, quote unquote, that did not support the position of the World Health Organization. I find that terrifying as an American and as a physician, that they would take it down for that, because the World Health Organization, in my mind, is essentially, an arm of the Chinese Communist Party. But the idea that I can't even put something out there that's informational. Now, I'm the first to admit, Facebook, Twitter, YouTube, Google, those are private companies. They are not, I am not afforded a First Amendment right with those companies, and I know that. So I don't have a legal leg to stand on. They can take down anything they want, but it sure as heck means that Americans need to understand, if they believe that they are being informed by going and searching things on Google, on Facebook, on YouTube, wherever they think they're getting their information, that they are only receiving information that they want you to see. It's highly distilled, highly censored, highly modified information.
Right.
So don't think that you're being informed.
No, Alexis de Tocqueville in the 1820s he was a French diplomat or aristocrat, really. Came here to study our penitentiary system. That was the conceit, but he ended up touring democracy in America, he wrote, touring across the country. And he said, we have the greatest privileges of free speech guaranteed in the government, but in reality, the least access to freedom of speech because of what he called the restrictions of the town square. That if you say things that are truly different than the prevailing wisdom, you will be crucified. And auto da fe is also the issue of the day. You're either burning the books or you're canceling people. Both are. Watch what you're doing, people. These are behaviors that have manifested many times in situations that ended up looking embarrassing in the retrospectoscope of history.
Well, and really what has made, if you just look at healthcare, what's one of the things that's made healthcare great in this country is my being able to have the kind of dialogue twice a week on these video calls with hundreds of physicians around the country where people are saying, here's what I was doing, here's what I did, this is how it worked. The open exchange of ideas.
Mm-hmm.
When we used to go, in our residencies or in hospital base, we had morbidity and mortality, where you go and you sit and you talk with your fellow physicians about bad cases, not so you could give each other a pat on the back and say what a great job you did, but so that you can argue with each other, but argue respectfully, say, why did you do this and not that? Or did you consider this? Why didn't you think of that? Or here's an alternative treatment. It's that exchange of ideas and a camaraderie and a willingness to have open discussion that has made us great. If we are only going to take one side of things and say, wow, well, whatever the WHO says, stamp, that's the imprimatur. Whatever the CDC says, you either get in line and speak that truth, or we're going to shut you down. That's a scary thing.
It is a scary thing, and now they've weaponized all kinds of things. I hope Dr. Emanuel makes it through without getting in too many entanglements. Is she's in trouble now, I hear? Of course, they're coming after her.
Well, they're coming after because people have learned that you can weaponize, as you said, that's the proper word, that you can weaponize things like the boards of medicine, file complaints against people, say that they're going to be responsible for the deaths of thousands of people because of this irresponsible rhetoric that they had on the courthouse steps. It's pure silliness, but it doesn't mean that it doesn't, number one, take an insane amount of your time as a physician away from your patients, away from things that you could be doing that are meaningful, and it's quite draining.
What do you feel about the quarantine of the public? Are you aware of the history of where that came from?
Well, let's talk about two different things. There's the quarantining piece, and then there's the social distancing component. So I'm here to say, there is no such thing in public health or in infection control as quarantining well people. We've used
until now, there suddenly has been. So go ahead.
Wait, so we've used the concept of quarantine, meaning to take an ill person, an infected person, and remove them from the public for centuries. We did it with leper colonies. We've done it with tuberculosis. Yes. We've done it with lots of things. It's very, very effective. It's sort of epidemiology 101, public health 101.
That's right.
We take sick people, we isolate them, we isolate the few to protect the many. We don't isolate the many to protect the few.
That's right.
That's called tyranny. Mm-hmm. That's a different thing. Quarantining healthy people is called tyranny. Mm-hmm. Now, the concept of social distancing, and I said this on the video that was removed from YouTube because I'm a heretic, apparently, but it was, that concept did not exist. I had never heard it, and I am trained in public health. I did my postgraduate coursework at the Harvard School of Public Health. I was on the Leadership Council at the Harvard School of Public Health for years. I had never heard the phrase social distancing. And so I went to my library of books on public health and on epidemiology and virology and pandemics, and opened every one of them. And I defy you to find a textbook in which the phrase social distancing appears in the content anywhere or in the index. So I looked to see, when did this start? And from what I can tell, and I'm not being flippant, it came from a high school science project back in something like 2006 that a high schooler who was looking sort of at a theoretical model of how a theoretical bug might spread amongst school children based on the number of people that school kids interact with on a daily basis compared to their parents, to adults.
Wait, were you separated at birth?
Because this is something I talk about all the time. So this is a. I actually pulled the paper. So it's a 16-year-old high school student.
Yeah.
Whose father worked at Los Alamos, and she was studying influenza, which is transmitted through children, kills children, totally different transmission mechanisms, influenza, and she concluded that distancing and isolating children at school or away from school could have an impact on influenza outbreaks. The dad, who was a computer programmer, a modeler, went, hey, I bet I could build a bigger model. And he essentially said, well, there could be some benefit on other sorts of transmissions through isolated lockdowns, not national lockdowns, not millions of people locked down. And he published a paper, put his high school student daughter as the number 2 author on the paper, and the Bush administration adopted it as policy. And that's where it got into the lexicon right there. No one had ever done it before. That was never intended to be massive lockdowns. Right. The idea of shelter in place is the most bizarre distortion of public health policy I've ever seen. But to be fair, let me state my opinion now. When my city and my government did this, I thought, okay, it's the fog of war. We really don't know where we're going. They're preparing for the worst case. I will support their decision. But now it's clear that we can live alongside this virus with proper measures and good treatments and build the vaccines and all those things we're going to do. We don't need these draconian interventions that have, as we discussed early in this conversation, massively adverse impact on other aspects of medical care and health and well-being and death rates. We have to have a balanced approach. And the government seems to be continuing, and the press certainly, in a spiral that they can't seem to get out of.
Well, and one of the things I do that we didn't talk about is I teach a course on leadership in times of crisis, really how people respond well in times of great disaster, whether that's an active shooter scene, a hurricane, a bombing, a pandemic. And one of the things we know, an adage from the military is that the first reports are always wrong. And in the heat of the moment, in the first seconds of any big disaster, the information you're getting is changing in real time. So I never fault people for their response in those first minutes, hours, maybe days of something. On the corollary to that is, in the face of new data, if you do not change course, if you do not change your approach, change your response tactics, when the data is replete now with evidence that we know something different. And for example, one of those things I would say now is we now know, Drew, that children are essentially zero risk from COVID-19. Okay?
But a 12-year-old died in Wisconsin. A 12-year-old died in Wisconsin.
Right. So we might not have known that back at the first week of February, but it's July now, and we now know that children are essentially zero risk, okay, from COVID-19. Furthermore, we know that children are very poor vectors, meaning spreaders of the virus.
That has been known from the beginning, and that is categorical. That is not open for conversation. That is for sure.
So we know that children don't spread it. So when you take those two things.
And by the way, there was an article in New England Journal this week that showed that they don't express ACE2 on their nasal mucosa.
Right.
So they literally don't have the receptor for the virus.
Exactly. And which is why they don't even need to develop antibodies. They actually just don't get infected with it. They harbor very small amounts of the virus in their noses and mouths when they become exposed. So now we know, here we are, we know that they don't get sick from it and they don't spread it. So what justification would you possibly have to close down daycares, summer camps, and school? Okay?
And we do know that they get impairments of socio-emotional development. We do know that they get depression and anxiety from being isolated like this. We do know that they get subjected to abuse that is normally picked up by the schools, is not getting picked up by them now. We do know that this is having a massive impact on these kids, and yet...
And the parents are going nuts.
And the parents are being subjected to employment stressors that could end up.
Somebody has a question. Are 17 to 18-year-olds spreaders?
Good question.
It's a great question. And what we know is that as kids get older, so sort of in that 15, 16, 17 age, they start acting more, as you might imagine, like an adult. So there is a question of whether or not they start to be able to transmit the virus. That said, if we look at the 22 European countries that have fully reopened for school, and that's with no restrictions, no masks, no social distancing, none of this craziness, in those 22 countries, they are not seeing an uptick in cases. They are not seeing transmission from students to teachers or from students to parents or elderly grandparents, even in that 15, 16, 17-year-old age group.
And to be fair to that somewhat as yet uncleared population, because we're adjusting as the data comes in the meantime, extra precautions should be taken. They shouldn't be out on the football field. They shouldn't be playing basketball. They should maybe wear masks at school. There should be some distancing perhaps, and be careful.
They can listen and learn.
I'm just saying that we adjust, and then as we learn more about it, then we'll adjust again.
So then the big argument to all that became, well, what about teachers? Because we need to worry about teachers. Okay, well, so let's look at that. Let's look at the data. In the United States, in the public school system, 56% of teachers are below the age of 40, and 80% are below the age of 55. So at least by age, 80% do not fall into the high risk category. So it seems to me that it's pretty easy then to rally around and come up with ways to protect those teachers or school staff, whether it's a custodian or the lunch lady or whoever it is, and rally around and protect those people. If I were a 70-year-old obese diabetic math teacher,
I wouldn't go in.
I might choose to not go in.
That's
or
right.
I might choose to wear a mask, or I might choose, frankly, less to protect myself from the kids than to protect myself from the other teachers in the teachers' lounge.
Absolutely. 100%.
But those teachers, but again, if you apply the construct of public health, which is you isolate the few to protect the many, not isolate the many to protect the few.
Absolutely. Let me address some people on the chat here.
I have a question too before she goes.
Hold on, please.
I have a big question.
Hold on, please. Friend Andrew Ashkazvili, time for a simple solution. I'm talking to those boys tonight on Fox 11, the Party Bros, Chad Kroger
Goes Deep.
Yeah,
Okay.
so look for that on the Fox 11 show. They're a great interview. It's this couple of guys that do improv, and they are the best public health messaging we've had in Los Angeles thus far. Trust me, when I tell you about it, you'll agree with me. And then GSR, we talk a little bit of a shorthand here, so let me repeat what we said. Children can't contract it because they don't have the protein on the surface of the respiratory tract through which the virus gets in. They don't express that protein. And that was published this week in the New England Journal of Medicine. So there's that. Yeah, these guys are, the public health messaging. Well, I've got so much. I don't know. Do you have to go at a certain point because I've got a bunch of stuff?
All right. No, all right. I'm all yours.
So the public health messaging to me has been just. Susan, you have your question. Go ahead. What's your question?
Oh, she said something the other day where you and I are having this conversation about the numbers and how some people might get it once, but they get counted 3 times as a COVID case. Yeah. And then also some people are standing in line and then they're not getting the test and then they're getting a negative.
Let's just start with what
this
percentage.
This is a debate Drew and I have.
My thing was, I'm sure it happens. Our systems are not perfect, but maybe it's 10% of the data at the worst. Do you think it's more than that?
I do. And here's, one of my mottos has been through this entire thing is the virus is real. The statistics are not.
Yeah, that's for sure.
And here's why. Let's start with the case number. The case number is off for a number of reasons. It's wildly inflated. Number one, if people get tested more than once, which many, many people do, because if they test positive, they're required to get tested, to have a negative test before they can go back to work or before they will feel comfortable going out and being with friends and family.
Let me just say, I'm sorry to interrupt you all the time, but the LA County Department of Public Health just put out a alert just now before we went on this screen that said you don't have to have a negative test anymore. You just have to have no fever for 24 hours unless you are in an ICU, in which case 10 days after you get out. So that's
okay.
Yeah.
But that's a change because it had
change.
So many people were tested 2, 3, 4, 5 times. And each time you come back as a positive, you are counted, unfortunately, as a new, quote, case. So that's preposterous. How can I, Kelly Victory, one individual, be more than one case?
Right.
But that's in fact what's happening.
Yeah. It's not like a podcast.
No,
we only get once. You only get counted once.
Right. So then many states, including Florida and Texas and others, were adding in positive antibody tests to the positive case bucket.
Mm-hmm.
So many people would get tested, be positive, and then say, well, I wonder if I developed antibodies, go get an antibody test. So then they're another case. So the case numbers have been really off. Then I started hearing these reports that I found quite alarming, and I've heard them from all over the country, not just anecdotally, but all over the country, that people said, I went to CVS or I went to a testing center, I filled out the paperwork, gave it to the tech or the person, waited, got to be 90 minutes, and I said, the heck with this, I'm out of here, left without getting a test, and 48 hours later got a call from the health department saying that they were positive.
Right.
And I've heard that over and over.
So have I.
Several physicians who I reference, whose names I will not give, who are on these weekly calls with me, did, and this is again in multiple states, Texas, Florida, and California, took tests, a group of 10 tests, did not use them, opened the vials, put them in, didn't use them, made up patient names, sent them into the lab, and had all of them come back positive.
Good boy.
So now I am not going to speculate whether that is a concerted effort to inflate numbers, whether that's a problem with the testing equipment itself. Is there a reagent issue that we aren't dealing with? Is it just abject incompetence? I'm not going to speculate. All I know is that I think that the numbers are off. More importantly, Drew, and I think this is where we need to focus, never before in the history of medicine that I'm aware of have we randomly tested hundreds of thousands of people for a disease for which they have no symptoms.
Right.
And the question is, it's one thing if you want to test everybody because you want to know the denominator. You want to know how many people in the United States actually had COVID-19 so that we can actually accurately calculate the mortality rate. That would be valuable. But if you're instead using that case number to direct public policy, which is what's happening, as long as we have an uptick over here or a spike over here, or we can't open the school because we have a quote outbreak, we are testing people who don't have symptoms. Huge numbers of the people being tested are asymptomatic. It would be tantamount
and positive.
Yeah, that's the point.
Right. That's
They're
not. There are cases there, but it would be tantamount to you saying, "Hey, I feel great. I was just on my way to the gym. I don't have any symptoms, but I just thought I'd swing by my doctor's office to get a test to see if I have strep throat." Right. Your doctor would look at you like you were crazy. Why would I test you for that? Or say, "Hey, I don't have any symptoms, but I'd like a chest X-ray to see if I have signs of pneumonia." I mean, we don't do that.
Yeah.
So
one of the
what
reasons
do you think that number?
One of the reasons we don't do that is, and people are not going to really understand this, this is a statistical reality, that the accuracy of the test is determined on the probability of it being positive.
Right.
So if you do a test that the probability of positive is 5 in 100,000, you're going to have way lots of false positives, lots, and won't really know what to do with the negatives. So it's accuracy is a major problem in that kind of widespread screening. It's a screening test then. It's no longer a test, not a diagnostic test anymore. It's a screening test, and those are designed differently.
Exactly. And so then if you go on to use that screening test, Drew, to dictate public policy, to make these far-reaching, overwhelmingly impactful decisions like keep schools closed. I heard one of the things that the teachers union put out in California was they were willing to open as long as there was a 14-day period with no new positives. Well, whoever said we were going to get that? No one ever talked about eradicating this virus. So we're setting standards.
Oh, look, in California, our LA County Public Health, their first position on opening was once you've had no deaths for 14 days. And I said, that's not, we're not going to have that till the vaccine is completely distributed everywhere. That's when that's going to happen. That was their official position. That's when I started thinking, oh my God, who's in charge over there? These are not medical people. But anyway, we got to kind of move along because I have to go somewhere in 10 minutes.
Sorry, I opened Pandora's box, but I swear it drives me crazy.
Two things. One of the things that I keep telling people is that the high risk populations are, of course, the nursing home populations, and we need to really have a much more thorough discussion about end of life and nursing homes. I mean, the average life expectancy after you've been admitted to a nursing home is somewhere between 6 months and 22 months, average life expectancy. Right. And so we are rushing into the ICU to save people for 6 months. And by the way, that if you survive an intensive care hospitalization, when your life expectancy is 6 to 22 months, your probability of living a year after that is next to nothing. And if you do live that year, it is the most miserable, horrible existence on earth.
That's right. And Drew, in the end, when we look back at this year and we look at what I call excess deaths, meaning the number of deaths that happened between, January this calendar year compared to the number of Americans who die in any other calendar year, the total number of deaths, that delta, that difference, the excess deaths is going to be really quite small because we're talking about people, when you're talking about an elderly person in a nursing home dying of COVID, they were in the process of dying of something else.
That's right. That's exactly right.
Don't get me wrong. I'm not trying to sound callous or uncaring.
No, it's just a fact. It's just a fact. Yeah.
And so, if you look at the number of deaths from...
When I was a resident, or back when I was doing intensive care medicine, it was considered just cruel to put an 80-plus-year-old on a ventilator. That was considered like really unethical. And now we're putting them all on ventilators for really unclear reasons. People don't understand. You can get them through the ventilated crisis, but when they come off, it is the most horrific nightmare of all time for the next 6 months.
There's a great article that someone sent me. They said the title was very sensational, as all of these have been recently. Tragedy of 13 nuns died in a convent somewhere outside of Detroit. And so I thought it was fascinating. I read it, and it's true enough. Apparently they had a bad outbreak of COVID-19 in their convent. and 13 nuns succumbed to it. The average age was 86. Okay.
Yeah.
Now, which does not make it less tragic, but it should have been really considered more of a nursing home than a convent. They happen to be nuns. But when you have people who are dying in their 80s, many of them, I think 7 of them were in their mid 90s. It's tragic, but they were going to die by the end of this year in all likelihood.
This is what people can't understand. They don't understand about advanced age. We have to help educate the public about that. Public health messaging, it's been inconsistent. It's been exaggerated. It's been this part of the First Amendment is protected. This part is not. It's been insane. And then they wonder why people aren't listening to wearing masks, for instance.
Yeah, and this has been where it's been botched the most, I think, because you've lost the public trust. When you start out of the box by saying, absolutely do not wear masks, masks do not work, and then go a 180, not only do they work, but they're mandated. You start with, we don't want to be in a group of more than 250 people, and within 10 days, we're 6 people.
Then 10 more days, there are 50,000 people in the streets, and that's a First Amendment issue, but not churches. You can't go into churches, so that part of the First Amendment we're not protecting.
Exactly, it's good. Costco, liquor stores are good. Church is bad. It's that inconsistency that I think frustrates people. It makes them lose trust, lose faith. And the problem is, as you know, we rely on people having trust and acting, at our direction in public health. And once you do that, once you do the sky is falling or, crying wolf one too many times, what I fear is that the next time when there is, and there will be something else.
They won't listen.
They won't.
This is the reefer madness theory. If you overstate, if you exaggerate something, they just forget it. But I'm going to interview 2 guys tonight that are these improv actors that play these sort of surfer dudes. And they went out to Huntington Beach and they handed out masks. And they nearly got beat up for just handing out masks. They didn't say, wear your mask. They just say, we got free masks. Anybody want a mask? And when you see, it's a narrative, it's funny, it's charming. And when you see people's reaction, the sort of the cognitive dissonance and the cognitive distortions associated with their aggression, it's a great message, which is if you're feeling this way, take a good look at yourself. It may be something more than just about the mask. There's something else going on here. So 5 minutes more, vaccines. Where are you at with that?
Well, let's start with saying, in general, I'm extraordinarily pro-vaccine. I'm a big believer that vaccines are critical. And when I mean that, I mean childhood vaccines that have been well vetted, chickenpox, measles, mumps, polio, those things that have been well tested. And frankly, Drew, for which there are significant consequences of getting that disease. I don't feel that COVID-19 falls into that category. 85% of people who get COVID-19 will have nary a symptom or a very, very mild illness. We know the folks who are at high risk. I have significant doubts about our ability to develop an effective vaccine. COVID-19 is a coronavirus. We have not come up ever with an effective vaccine for other coronaviruses, common cold being one. All viruses mutate. Coronaviruses are particularly good at it. They mutate quickly. So I have my doubts. There's a reason why influenza, for example, the vaccine is never even approaching 100% effectiveness because it is made and modeled after the outbreak the year before. So in a good year, it might be as much as 69 or 70% effective. In a lousy year, when they don't guess well, it might be only 25% effective. So I wonder about the effectiveness of it overall. But as I said before, more importantly, how much I would need to take something like that when I know that I, for example, am not in a risk category. Yeah. And if I were to get COVID-19, I would, just like I don't want to get influenza, but I won't likely succumb to it.
Right.
So I don't think people should be hanging their hat on a vaccine. The idea that, for example, we can't get, and I've heard this a few times too many, that we can't get back to normal until we have a vaccine. Well, there's no saying we're ever going to have one. There are a heck of a lot of viruses out there, Drew, that have been around a lot longer than COVID-19.
Sure.
Like, herpes, Ebola, Coxsackie virus, norovirus, HIV. There are a lot of viruses that have been around a heck of a lot longer than COVID-19, for which scientists have never created an effective vaccine.
So let me this is where you and I diverge a little bit here. So I had H1N1 and it nearly killed me. It was, horrible. Like I can't even tell you horrible. And as I look back on my own history with viruses, I have metabolic syndrome and I'm over 60. And so I think I have some sort of whatever that genetics are that set up the cytokine activation. I think I got it. So for me, vaccines make sense. And I am happy to help be a part of the human subject pool that moves that science forward. So I've signed up for phase 3 on the Moderna vaccine. I hope they'll take me. So just because I think I love the technology, I've read the papers, it looks good to me. B, I think I'd like to help. I like to help out with the human subjects. Go ahead.
And don't get me wrong. No one should take away from this that I am anti-vaccine. As I said,
I get it.
I'm pro-vaccine, and I don't think you're risking yourself taking the vaccine. I'm not suggesting that either. I'm just saying that I wouldn't wait the idea that we're not going to go back to school or open businesses or get back to life until we have a vaccine. It may never happen. I think we've got other mitigation strategies that will work. And those people, just like with influenza, those people who are in a risk category and you've self-identified to be, which you consider to be a risk category, you should absolutely take a flu vaccine. And I would say support taking a COVID-19 vaccine if they actually come out with one.
And in reality, I'm probably in a minority for my enthusiasm for this stuff. You're probably closer to the middle ground that a lot of doctors are in. I know that Dr. Oz interviewed, I forget the guy's name, it's like Hoykins, who's the big vaccine guy. And he wanted to see a 6 or 8 month track record too before he really signed off. He was a little worried about the newer technologies. So it's, this is medicine. This is science. This is how we do it. This is our morning report. We disagree on everything. That's a ball game. Right.
Yep.
And so, but I do believe vaccines, and I think you would agree with this too, that it will be part of what lets us get back to a normal HOTES. Right. Thank you, Andrew. Gets us back to a normal. Well, that and. Well, you've made me feel something a little different, which is I sort of had a view that, the vaccine will come and the press will settle down, but maybe they won't,
No, I think, I'm not sure what's going to make it settle down. I used to think that this would somehow change, come November. I really don't believe that that's the case. I think this has been internalized by too many people. And the fear factor, one of the other things I will tell you that I know from teaching a course on leadership in times of crisis is that the time you cannot make good decisions and you cannot lead when you are in a place of fear.
Yeah.
And unfortunately, I believe that many of our public health leaders and elected officials are working out of fear, and they just are shotgunning it. It's a knee-jerk reaction. And so they're constantly trying to correct their course based on, we had 10 more cases, or somebody got in the ICU here, or this happened. And if the analogy I make is, it's like driving a boat. If you've ever driven a boat across a body of water, if you try to correct it every time a swell comes and pushes you, all you do is correct, and all you do is zigzag across the water or go in circles. Yeah. You can't make a straight line anywhere.
Yes.
You simply can't try to correct based on every new piece of data that comes down the pike in an hour-to-hour basis when we're dealing with something like this.
And there is something about the quality that you're talking about, decision making, strictly speaking, of leaders. Yes. There's something about the behavior of most of our leaders that has been, I'll be kind, less than inspiring.
Yes.
And it's been a really disturbing phenomenon. And again, it's led me to go, geez, I think I have to run for office just because I feel obliged. I feel like somebody's got to get in there and do something. I mean, this is insane. But
yes, I agree.
I'm thinking better of it now. Let's put Dr. Victory up for something. I think she's primed.
Yeah,
she's ready.
She's great.
All right. So your best friend, Susan Pinsky, any last questions for Dr. Victory? Susan?
No, I think you had some good questions on the restream. I don't know if you can pull a couple of them
It's hard,
out.
you guys. I had so much myself.
Well, I do have one question. Okay, so if we got a vaccine and only half the people took it, how are they going to make sure everybody took it? And
they're not.
Are we just going to go back to the way it was and let a bunch of people die? That are we going to get shut down again because people don't want to take the vaccine?
It's an interesting question.
Well, I certainly hope. I would be extraordinarily opposed to mandatory vaccines for something like COVID-19.
They're not going to do that. Yeah, they're not going to do that.
So I'm certainly we're not going down. But here's the point. We know, and we've been able to identify from the beginning who the at-risk group is. It's very easy for us to rally around and protect that group of people. We know who they are. Right. The great news is that compared to, say, the Spanish flu outbreak in 1918, this one hits that, people in those elderly decades. And although we say over the age of 65, let's face it, it's really been over the age of 80.
That's right.
Only 6.5% of the American public is over the age of 65. And then over 80 is, like 2%. And they're not in the workforce anyway. So we could have done this. We could have rallied around and protected that at-risk group of people without making overwhelming decisions that profoundly impact the livelihoods and the economy and everything else that goes along with it of millions and millions of people. We could have protected those. And so my suggestion from the start and going forward, Susan, is that independent of a vaccine is let's rally around and protect the people who we know are in the high risk group and stop doing things that is impacting people who aren't in that group. And I would start.
I said that from the beginning.
Well,
right, Drew?
Yes.
I did. But also somebody asked what metabolic disorder was, Drew.
Metabolic syndrome is essentially, it's a genetic profile a lot of people have. It's hypertension, hypercholesterolemia, insulin resistance, central obesity, sometimes antiphospholipid.
High blood pressure?
Sometimes antiphospholipid syndrome can go along with it. It's a particular syndrome. If you guys listen on August 11th to the Dr. Drew podcast, I interview a physician that's trained in the biochemistry of diet. He's very good, and he talks about what really the underlying physiology of this is.
What's his name? August 11th.
Yeah, you're gonna, Dr. Paul Saladino.
Oh, there you go. Saladino. I knew you could do it.
Look for that one. He's really good. You look him up. Just go to Dr. Paul Saladino, look his stuff up. It's very technical, but he does a good job of describing it. Kelly, pleasure to see you again. I hope we can talk to you again soon. Good luck with everything. Whatever I can do to support what you're doing, let me know. And
did not disappoint, Kelly.
No, whenever anybody knows what they're talking about, physicians don't really disagree amongst themselves, and we disagree on subtle things, just like we did about vaccines, and we don't have massive disagreements on this topic, on anything to do with this COVID. I mean, we're all out there practicing and dealing with it. We're all seeing the same thing. We're all using the same tools to combat it, and yet the public discourse has spun into some bizarre place that none of us can recognize, and unfortunately it's bleeding into our ability to deliver care.
Right. Yes,
that's the problem. That's the problem.
And vilifying people for having a differing opinion. We're saying no one's trying to downplay this virus or certainly harm any individuals. My goal, as I said from the beginning, is to look at not only the individuals, though, the impact on the entire population, which is the mandate of public health. And I think we've fallen short there. So happy to be back anytime, any topics. Great fun.
Also, we had really positive Restream views and or comments, and I just want to say thank you to everybody for not canceling us during the show. We appreciate you listening to our point of view.
I don't think
it looks really good. We have a great following,
but we're not taking a radical point of view. To me, the idea that this is even controversial to listen to what Dr. Victor is saying to me is medicine. It's bizarre. I mean, if you said something that was way off, Kelly, I would. Just like we disagree on the vaccines, I would say, we disagree on that. No, it's just that we've been practicing medicine sort of the same amount of time, and we're sort of experiencing this thing now in real time, and it's just what we're experiencing. We're just reporting what's happening, and our perspective as clinicians who are out there in this. So. All right, again, I got to run. I got to go do this. Ooh, I'm late. So, Kelly, thank you so much. And everybody else, we'll see you tomorrow. We've got a guy, on Thursday, guy coming in who was a homeless person. Now he's a director of nursing.
Oh, wait, let me find the banner.
He's now director of nursing in a facility that treats homelessness. And guess what? He and I aren't going to disagree on how to deal with homelessness either. And yet I've not interviewed him either, but I guarantee you he and I are not going to disagree on very much.
He's Thursday.
That'll be Thursday, and then Tyrus tomorrow.
Yeah, we have Tyrus in here tomorrow
with
his
wrestlers that are going to try to convince me to run for office. So good luck with that, everybody.
Yeah, so back to politics and craziness there.
Okay, guys, thanks so much. Thank you, Kelly. We'll talk soon. Bye-bye, guys.
Sounds great.
Bye.
Thanks.
Bye.
Bye.